Thank you very much for that very kind introduction, Professor Farshid, and thank you very much to Roche for supporting this breakfast symposium. So today I'm going to be talking about some data that's relatively hot off the press. Most of the data was collected and assembled by Madeline as part of her PhD. And it's really about designing a trial to assess the efficacy of an algorithm to assess HER2 ISH in difficult cases that we encounter on a day-to-day basis. We have to make some disclosures. This breakfast symposium is sponsored by Roche Diagnostics Australia, and as a member of the Pathology Technology Australia, Roche Diagnostic abides by PTA Code of Practice. My disclosures: work presented in this presentation was performed on equipment provided by Roche Diagnostics, who played no role in the study design, data collection, interpretation, or conclusions. My institution has received honoraria and registration, and also from MSD and Leica. So for our international colleagues that are here today, I'll just talk a bit about eligibility for HER2-targeted therapy, which is different in Australia to different parts of the world. And in Australia, HER2-targeted therapy, whether it be Herceptin or pertuzumab, it requires demonstration of amplification by in situ hybridization. And the only other jurisdiction in the world that I know of is Thailand, that requires a 3+ staining to be confirmed by ISH. But everywhere else, the UK, in America, a 3+ immunohistochemistry stain for HER2 actually is positive and doesn't need to be confirmed. And as a consequence of that, in Australia, we've got many laboratories performing HER2 in situ hybridization. Commonly, it's the Ventana single ISH, but at Mater in Brisbane, we've used dual ISH assays for at least 10 years now. And in other countries, equivocal HER2 stains are often sent to specialized centers for FISH testing, whereas we really have a distributed system in Australia. Most laboratories are able to run dual ISH staining. So a lot of breast pathologists have a lot of experience in reporting dual ISH. And it's really, and that's why the numbers that you'll see in this presentation are quite large. So in 2018, the ASCO-CAP clinical practice guidelines produced a focused update to provide specific guidance about less common HER2 patterns, which represent approximately 5% of cases which are equivocal for HER2 IHC, the 2+ cases. And this guideline, clinical practice guideline, it clarified the criteria for in situ hybridization and immunohistochemistry review for groups 2 to 4 to arrive at the most accurate HER2 status designation. That's calling it either positive or negative. And for us in Australia, what this meant is it removed the requirement to perform HER2 in situ hybridization for cases that were either negative, 0, or 1+ on HER2 immunohistochemistry. And part of the data that was behind this change was that the NRG trial B47 provided data that showed that patients that were HER2 1+ or 2+ and negative by FISH, adding trastuzumab to standard adjuvant chemotherapy did not improve disease-free survival. So that allowed us to stop doing reflex HER2 ISH testing in patients that were negative or 1+. And so the groups that were produced by this focused update include the classic HER2 amplified cancer, the group 1, which these are the ones that generally have high-level amplification. There are patients that have low-level amplification as well, but they have ratios of greater than 2 and HER2 copy numbers greater than 4. But 5% of cancers are in the groups 2 to 4 range, and group 2 represents patients that have monosomy 17. That's with a ratio greater than 2, but copy numbers less than 4. And these were classified as being negative unless there was concurrent IHC 3+ staining. Each of these groups 2, 3, and 4 requires additional workup. And that additional workup requires a second opinion from another pathologist who also looks at the immunohistochemistry to determine an overall score. In the group 3, the co-amplification group, which represents relatively small numbers, with a mean copy number of greater than 6 and ratio less than 2, This was retained as being positive if it had immunohistochemistry score 2 or 3. The borderline group, which was the biggest change, was with copy numbers group between 4 and 6, was called negative, unless concurrent immunohistochemistry 3+. And in our laboratory before that, these were called equivocal and often referred for another test, such as fish testing. And group 5 is just the classic non-amplified cancer, which is less than 2 or a copy number less than 4. So how are the guidelines implemented in standard practice? So in our practice, if a case is 2+ and falls within groups 2, 3, or 4, as per the guidelines, you have to recount the ISH by an additional observer blinded to the previous results. So you can't tell the other pathologists what the results are, but they kind of know because you're giving them a case for a second opinion for the ISH count. So they kind of put their wings up that it's probably a group 2, 3, or 4. At least 20 of the cells have to be counted by a second pathologist in the area of the 2+ staining, and if the count is the same, it's recommended to be reported as per the table I just went through before. So negative for 2+ in groups 2 and 4, but positive if the patient's in group 3. But if the counts are different, and I did notice this did happen sometimes, it was to adjudicate as per internal procedures to define the final category. We don't have specific guidance about what those internal procedures should be, but in most people's practices, which involve referral to a third pathologist, sometimes people do refer this still to for another assay, which is specifically not recommended by the 2018 ASCO CAP guidelines. So note, if there's a 2+ case is borderline group 1 amplified, so copy number, for instance, 6.1, or borderline non-amplified with a copy number of 3.9, for instance, no second count is required, and you can sign that out straight away. So why do this second count? Why do the guidelines advocate for a second pathologist to be involved in this case and count and report the case secondary? So it's inferred that there must be a degree of interobserver variability about these cases in these difficult to report cases. But really, when we try and interrogate the data around this, there's very little data to support this assertion. Our experience was that interobserver variability is a significant issue, and it can be down to which cells are counted, small areas of heterogeneity which can be difficult to find, and basically just which fields are selected for enumeration. And under standard light microscopy, it can be very difficult to get an overview of the entire slide of the signal of HER2 ISH, which is really only visible at 40 times magnification and higher. So we had to sort of come up with a plan to document whether interobserver variability was a problem in equivocal patterns of HER2 ISH. So our study aims was to determine whether significant interobserver variability was an issue in HER2 DISH assessment, and if there was interobserver variability in manual counting of HER2 ISH, can we use a digital algorithm to improve concordance between pathologists? Secondary aims of the study were, can we define subgroups most likely to generate interobserver variability, i.e. is there particular histologies, and I was thinking potentially micropapillary carcinomas, or particular groups where the group 4 cases generated high levels of interobserver variability. These were our secondary aims. And will an algorithm enable us to produce an assessment of HER2 DISH faster? Is it faster to report for pathologists? So to try and address the study outlines, these are the ASCO CAP guidelines for reporting groups 1, 2, 3, and 4, 5. And we generated some numbers around those guidelines to capture a breadth of cases that included all of the 2, 3, 4 cases, but we also included those cases in group 1 that were low-level amplified, so copies less than 7 and ratios less than 2.5, and also those cases in group 5 which were borderline negative, which had, well, borderline in group 5, ratios of greater than 1.8 and copy numbers greater than 3.5. So what I was trying to do was trying to generate a cohort that represents the most difficult cases that we encounter in breast pathology in day-to-day practice, and to really test whether these were reproducible amongst pathologists. So what we did was that we had done 2,982 DISH cases between 2013 and 2019. 2013 was very specifically chosen because that was the year that the ASCO-CAP 2013 guidelines were enacted, but also we had done dual-ish for the whole time in that period, and we had sufficient numbers when we included that. And we excluded 2,097 who were immunohistochemistry score 0 and 1 plus. So we no longer perform DISH on 0 and 1 plus cases, left us with 885. We excluded those that didn't meet the ISH criteria as per the table, and that excluded quite a lot of those cases, 783. So we were left with an enriched cohort of 102 patients. So one thing I forgot to mention was that we also included a group of patients that had heterogeneously amplified HER2 DISH, and there was a comment in the report that it was amplified with heterogeneity. Patients that are not amplified with heterogeneity were unable to be retrieved because there was no comment in the report generally in those patients. So we ended up with a cohort of 99 patients, representing the most hardcore difficult group of HER2 ISH cases that we come across as pathologists. And I asked more, but I actually got 4 pathologists to report all of these cases manually. They had a new H&E, a new HER2 immunohistochemistry stain, and a freshly stained HER2 DISH assay. Why did we have to repeat the HER2 DISH assay? Because the HER2 DISH assay chemistry changed in about 2019, and the algorithm only works with the new version of the assay. So that was another complicating factor. We had to rescore all of these cases manually. And this is the first interobserver variability study I've been involved in, and I'm not sure I'm going to do another one again. It was a lot of work to get everyone to score these. Okay, next slide. So this is a video just showing you the software, so to give you an idea of how it works. You select your case, and this is Madeline driving the slide, and this is a metastatic carcinoma to a lymph node in this case. It's just a case that we pulled out for an example. And you can review the H&E slide as per any image viewing software. This is the HER2 immunohistochemistry slide that we had access to, showing you the areas of staining, so that you can use this to target your ISH counting. And then here is the HER2 DISH assay. And what I'll point out about this is the heat map. Oh, sorry. Okay, and so here's the DISH assay. The heat map will count every cell on the slide and show you areas which are more likely to have amplified cells and areas that are red and black. You can see the control at the end of the slide, black high-level amplification and lower-level red amplification. And as you zoom in, the assay will, the algorithm will select cells which are potentially able to be enumerated, that it fulfill its criteria for enumeration. At this amplification, you can select region of interest, and it will select some cells for enumeration. You have complete control over which cells to count or not count. So if you're not happy with any of the ones it's selected, you can deselect and select other ones. So it really is a pathologist-supervised algorithm. This doesn't replace what the pathologist is doing. It's just providing a suggestion. And so here we're selecting another representative cell when we didn't like a cell that was selected. So most of the case it is picking cells which are representative of the invasive cancer, representative of the overall amplification status. And once you're happy, you can click enumerate. It will give you the statistics for the counting cells. It'll tell you exactly how many dots are in each cell that are enumerated, and when you're happy with the report, you can just click accept and it will generate a report at the end of it. So that's just to give you an idea about why we thought this algorithm would reduce interobserver variability. So the heat map and enumeration. Okay, so I'm going to pass over to Madeline, who collated all the data and did all statistical analysis.
Good morning, everyone. As Cameron mentioned, I'll talk through a little bit more about the study design and then get into the results of this study. So we really wanted to mimic our clinical workflow as much as possible in this study. And so we commenced by doing all the data extractions that Cameron talked to you about and actually developing our list of enriched patients for this cohort. And then the first thing we did was we actually created a research-specific test code, which we used to enter into our pathology LIS, which for the Mater Hospital is still Kestrel. Following this, we got all our blocks out of archival storage and resectioned, as Cameron mentioned, to generate a new H&E, HER2 IHC, and HER2 dish slide. The staining was done on our benchmark Ultra, and following this, we actually scanned all the slides using the Roche DP200. Following this, as Cameron mentioned, we managed to get 4 breast pathologists to actually manually score all 99 cases for this cohort. After they had completed scoring, we had a washout period of about 2 months, which helped them forget what they had just been through and move on to, during this time we also completed a second round of de-identification, which involved changing the sequential order of the cases within the study. Following this, our pathologists actually rescored all 99 cases using the Roche UPath HER2 dual ISH image analysis algorithm. So just briefly about our study cohort. As Cameron mentioned, our cohort was selected on the basis of the original pathology report. And what we found is we had a mixture of groups, we had patients from groups 2, 3, and 4, and borderline groups 1 and 5. And what we found is that the numbers that actually we had in these groups were in line with published incidences of the groups, in keeping that we had the highest number of cases in group 4, which is our borderline equivocal group. This is just some representative staining images of our H&Es, our HER2 IHC, and our HER2 ISH slides for each of the subgroups that we included. It's important to note at this stage that the pathologists had all 3 slides for both the manual and the digital pathology scoring aspect of this study, which obviously helped inform their analysis. So into some of the results. We were interested in looking at the interobserver variability in our overall cohort, which included both 2+ and 3+ IHC cases. On the left-hand side, we performed analysis called a Fleiss kappa, which looks at the inter-rater agreement between our pathologists at the level of HER2 overall status. And this means we're looking at the level of concordance in terms of if they call the case positive, amplified, and therefore the patient is eligible for HER2 targeted therapy, or negative, non-amplified, meaning the patient is not eligible for therapy. And what we saw is that there is significant interobserver variability in our current gold standard practice of reporting dishes using light microscopy, with a kappa of only 0.471 and a confidence interval that indicated there was only fair to moderate agreement in our current practices for these challenging cases. When we performed the digital algorithm analysis, this kappa increased to 0.66, and with the confidence interval, that was a moderate to substantial level of concordance amongst our pathologists in reporting. Similarly, on the right-hand side of the screen, I performed an intraclass correlation coefficient analysis, or an ICC, and this analysis looks at agreement at the level of the ASCO-CAP groups, so whether the pathologists are able to call it consistently group 1, group 2, group 3 within the study. And what we saw here is that, again, there was a high level of interobserver variability in the manual reporting of these ASCO-CAP groups, and that level of concordance was improved through the use of a digital algorithm. Following this, we were interested in doing a subset analysis that actually looked at cases that were identified as having heterogeneity from our 2 and 3+ cases. So cases were identified as having heterogeneity if there was a comment in the original report or if any of our 4 pathologists made a comment about it in either the manual or the digital scoring. So again, as you can see here, our level of concordance in our cases with heterogeneity was marginally lower than those without heterogeneity. And for both instances, at level of HER2 overall status, we saw improved concordance in reporting of these cases with the use of the Roche digital algorithm. This was similar to what we saw in the ICC analysis, was that our level of concordance improved from poor to good through the use of the algorithm. We were also interested in doing a little bit more of an exploratory subtype analysis where we looked at whether the level of concordance changes in different histological subtypes. Now, unfortunately, we weren't able to generate statistically significant data for our special subtypes that include things like micropapillary carcinoma, invasive lobular carcinoma, or metaplastic carcinoma, because the numbers were simply too small in our particular study. We were able to look at invasive breast carcinoma of no special type, and what we saw here is that the level of concordance was only fair to moderate in reporting this subtype, and that improved again to moderate to almost perfect with the use of the Roche digital algorithm. Now, as Cameron mentioned, in Australia, we're one of the few jurisdictions in the world that still does reflex-ish on 3+ cases. So we were interested in mimicking global practice and looking specifically at our 2+ IHC cases to see if there was differences in concordance in this subset. So in only 2+ IHC cases on the left-hand side, you can see at the level of HER2 overall status that is assigned by the pathologist, we have significant discordance in reporting. We have a kappa of only 0.356, which is fair to moderate at best. And so this is significant. This is lower than what we saw in the overall 2+ and 3+ analysis earlier. And so this level of concordance was improved significantly by the use of our UPath HER2 ISH algorithm, and it improved to 0.6, I think it's 22, for moderate to substantial. This was similarly seen when we looked at the ASCO-CAP groups that were designated by the pathologist. There was a very low level of agreement in actually assigning the ASCO-CAP group to the cases, and that was improved with the algorithm. We went on to perform the same subset analysis to say, cases that are 2+ with heterogeneity, how does this affect the interobserver variability in reporting? And what we saw again was similarly that cases with heterogeneity that had 2+ IHC expression had marginally worse concordance than those that did not have heterogeneity. And the level of improvement in our concordance through the use of the digital algorithm improved from fair concordance to substantial. And at the level of the groups for the ICC analysis, they improved from poor to good. And what we can see is that there's reduced concordance in the manual assessment of cases with heterogeneity, and this is improved through the use of our algorithm. We were also interested in performing a time comparison analysis to really assess whether the use of a digital algorithm can improve the rate at which we report these ISH cases, because many of the pathologists in the room would know they can be quite time-consuming and challenging to report. And what we found was that there was a significant reduction in the time taken to report these cases. Some of you might be looking at the mean and median for the manual reporting of HER2 ISH and thinking 4.5 minutes is quite fast to report a dish. But keep in mind, our pathologists did have to report 100 of these incredibly challenging cases, and we think that might have had something to do with the speed at which they were reported. But what we did see was that the algorithm was able to reduce the time taken to report to a range for the mean and median of about 1.5 minutes. The higher maximum level for reporting you see there for the algorithm, 5.5 minutes, was likely, we found was due to cases that had really small deposits, had heterogeneous amplification, and the pathologists had to spend more time actually deleting and selecting cells in this case to get a representative field that they were happy with for reporting. I'll just hand back to Cameron for some concluding remarks on the study.
Thank you, that's great. So, is accurate HER2-ish quantification actually necessary? Well, I'd argue absolutely. So in early stage breast cancer, low-level amplification will direct patients towards a very definite treatment pathway, and that's often in the neoadjuvant setting to HER2-targeted therapy, which may be Herceptin plus or minus pertuzumab. So identifying those patients with low-level amplification is really important. Expression in the absence of amplification, particularly in locally advanced or metastatic breast cancer, is more and more being discussed as an area that might respond to antibody-drug conjugates, and those patients would belong in the HER2 low group. So the distinction between HER2 low and low-level HER2 amplification is where we've really focused this study. And those patients that are not amplified may have novel treatment options. The Destiny trial demonstrated TDM1 benefit in non-amplified metastatic breast cancer, and I understand there are trials ongoing in the adjuvant setting. And directing patients towards trials of HER2 low treatment includes trials with immunotherapy agents in combination with HER2 targeted treatments. So it is really important to accurately quantify where these patients sit and to make sure that they have the most accurate diagnosis of HER2 possible. So what do we think the future is of HER2 DISH algorithms? Well, we have shown that there is interobserver variability which can be reduced by the use of an algorithm to assist assessment of HER2 amplification. What we don't show is whether these patients will necessarily benefit from anti-HER2 targeted therapy. As a retrospective cohort, these patients have a mixture of being treated with HER2 targeted therapy and not. But in practice, this trial is very difficult to design. The number of patients that belong in this group is small, and in order to design a trial to see whether these patients would benefit, you would have to have a control arm, which isn't an ethical study to perform. Accessing retrospective tissue is another way you could potentially answer this question from previous clinical trials, but as we found, there are issues with performing DISH assays on old samples, which we had a high attrition rate for quality, so up to 25% of patient samples were not sufficient for quantification by pathologists, and we think that's probably an age-related issue due to the limitations of a retrospective cohort. So I think, our proposal is if an initial HER2-ish assay is in groups 2 to 4 or borderline amplified or borderline negative, consider the use of a digital algorithm to determine status. But there's also the benefit of using an algorithm in just routine day-to-day-ish reporting. It will be faster, and in those patients that are negative, an algorithmic approach, it really helps you not miss small areas of heterogeneity within a case. So it will highlight those cases very quickly and easily that have small areas of amplification that do have the potential to be missed. So in conclusions, we make the conclusion that there's significant interobserver variability in the interpretation of HER2 DISH assay in this cohort, which is enriched for less common patterns of HER2-ish using standard light microscopy. And that is a contribution to the literature that doesn't really exist. The use of a digital algorithm improves interobserver concordance in this cohort with less common patterns of HER2-ish, and this does have the potential to improve patient selection for HER2-targeted therapies and also includes novel combinations and antibody-drug conjugates in the HER2 low group. We've got lots of people to thank for this study. Madeline, who's spent a lot of work in the dungeon retrieving cases and entering data and learning how to do stats and R, which has been great. And we just acknowledge all our funding, Roche Diagnostics for their support in supplying the material required to do this, the RCPA QAP research grant that helped fund this, and Marta Foundation that has also funded a lot of this work, and all the pathologists that have been involved, and the Roche team who were really useful technical support for us. Thank you very much.
Thank you, both of you, very much for that, for those presentations. Certainly, evaluating the HER2 status of a breast cancer patient is one of the most significant contributions of pathologists. And it's a heavy responsibility, and having more objective tools for doing this is a welcome development in my experience. It's more important than grade, basically, what we say the HER2 status is. So are there any comments or questions from the floor? Yes, go ahead, please.
Yeah. Thank you. I actually, there was a great presentation today and also yesterday by you, and I was always have a kind of a silly question, you know, for this kind of HER2 new evaluation. I know we right now currently doing is that first by the immunohistochemistry, and then followed by the in situ hybridization, seems like a backup. Particularly as yesterday you talk about, you also perform all the in situ hybridization from 1 to 3. So I'm kind of wondering why we have to do immunohistochemistry. How about just go one step to go into the in situ hybridization to make the analysis a final decision to get rid of one step? So that's my question.
I guess it's a health economic question. Particularly in Australia, the government has negotiated quite reasonable prices for SISH. We have availability of SISH, but FISH is much more expensive than immunohistochemistry. I think the reimbursement for IHC for all 3 markers is something like $70, whereas we get $270 if you add SISH in Australia. In the US, those prices are far higher, so that the burden, because this has to be, if you're what you're proposing to SISH on everybody, the budget for HER2 testing is going to be magnified at least 5 times, which is going to be, well, no more than that, much more than that, 10 times, I think. So it's a health economic question, which pales into insignificance when you consider the cost of the treatment, but that is what. And also there is very good concordance data to show that the 0s and 1s, the rate of amplification is very, very small. It's not 0, but it's very small. So that trade-off has been made. Cameron, do you have any other comments?
Well, I think ultimately it's also worth remembering that HER2 targeted therapy works on the protein. And so it is really good to see what the expression is of the protein on the cells, because ultimately that's what, when you're treating a breast cancer with HER2 targeted therapy, it doesn't care what the amplification status is. It depends on the surface level of the protein. So I think it is really useful to have both. And it's a really great quality assurance to have high-level amplification with your HER2 high-level expression. And yeah, it is a cheaper option
robust,
as well.
And quite robust.
Robust, yeah.
I have a question. So we know that there's variation between pathologists, and it's almost certainly because they go to different cells for their evaluation. So with the use of the algorithm, does the algorithm give pathologist 1 the same cells to evaluate as it does to pathologist 2, or when you go to a second pathologist, does the algorithm kind of start afresh and choose different cells? Do you know that?
So the way the algorithm works is it scans the slide, and then as soon as the slide's scanned, it goes in, the data goes into an algorithm server, which analyzes every single cell. It takes about 20, 30 minutes, depending on how many Pentiums are in your server, to quantify every single cell. And it's not actually available to the pathologist to look at until that quantification is all done. But for each pathologist, they were given a blank algorithm, so they had to select the area they wished to score for enumeration. And within, if they both selected exactly the same area, then yes, the algorithm will show you the same 20 cells, but it's almost impossible that
Sure.
the pathologist would select exactly the same area, the same pixel.
Yeah.
So they get to report it fresh each time.
Okay. Okay, so that's interesting. Yes, go ahead, please.
Thank you. It's a great talk. I'd like to ask a little bit about the pathologist behaviour, and it's awesome that you got your colleagues to do this. Reporting 99-ish is not a small feat. So my question is, that could be considered a really very large training set. Did you look at all at assuming that everyone started at the beginning and went to the end, did you look at the difference between, say, the first 25 cases and the last 25 cases and the variability between those subsets with regard to interobserver variability? So does that training actually change the interobserver variability?
Well, we haven't done that. In terms of the pathologists using the algorithm, we all attended a training session before the study on how to do that, and there were a few, I can't remember exactly how many practice cases there were to report to make sure that everybody was comfortable with how the technology worked. But that is an analysis we could do. We haven't looked at that.
It would be complicated by the fact that we had 4 pathologists to score the same 99 set, and obviously we had 1 set of the slides. So yeah, they didn't start at the same point in the study, which makes it complicated. One started at the end, one started at the start, one in the middle sort of thing. So they would return them to me, and then I would change the cases for them. So it would be difficult to do, but that is an interesting consideration and perhaps a flaw in the setup of the study that they couldn't score them in the same sequence at the time.
It is a bit of an artificial situation,
Yeah.
though. You give someone 99 cases to score. It doesn't reflect routine practice, that's for sure. Yeah.
How often did you find that you wanted to change the cells that were offered up to you?
So this is a very distilled cohort representing what I think is the most hardcore, most difficult group of cases. And I would estimate, and we don't actually record this, did we?
No.
So we have no way of knowing other than sort of anecdotally, but probably 20-30% of cases would require some tweaking of the scored cells. Overall, the impression of the use that I got from the pathologists was that it was very positive. Nobody really minded doing this part of the study.
Yeah, it was a lot faster.
Yeah.
The algorithm is very good at segmenting the cells with a high degree of confidence. So the ones that it does select to score have both your HER2 and your chromosome 17 signal. They're your round cells that aren't overlapping with neighbouring cells and have a high degree of segmentation. So in that regard, it was quite good at selecting representative invasive breast carcinoma cells for the pathologist to score, but obviously there were the incidences where you would need to change 1 or 2 depending upon the selection.
So in terms of the logistics, do you know where Roche are with offering this product and whether the slides need to have been scanned on a Roche scanner for it to work, and just some of the logistics? I don't know if you wish to comment or if we've got one of
we
the
have
Roche.
a lot of Roche representatives in the room.
Luke, do you want to, who wishes to take this one?
I can
We can
talk about
do
it.
that.
Yeah.
Yeah.
The algorithm, as we've learned, the algorithm only works currently if the slides have been scanned on a Roche scanner. It has to be scanned at high magnification, so the highest
40
at 40
times,
times to get the resolution that's required. In terms of the assay, we've just been using it as a research tool in our laboratory, but I understand it is a TGA-registered IVD.
Okay.
So it is available to be used in Australia once you've done a verification in your own laboratory. our use of the algorithm, we quickly noted that it's actually, whilst you can get the data out of it, it's reporting as per the product insert, which is different to the ASCO CAP 2018 guidelines. So it will ask you for a second count if you get an equivocal amplification. But that's not really affecting the performance of the algorithm, it's the performance of the reporting tools. So there are things that I understand are being worked on.
And if pathologists are keen to engage and give this a go, how do they, what's the mechanism for access and kind of contributing to further developments? Do we know?
Speak to your friendly Roche representatives here today.
Yes.
Yeah.
Yeah. All right. Well, I think we've reached the end of the session. It remains for me to thank our presenters for an excellent job this morning. Thank you very much for your magnificent contribution. It's a lot of work, and to your colleagues as well. Thank you. Good luck with the PhD, Maddie.
Thank you.
and thank you so much, all of you, for attending. Really appreciate your comments and your participation. Thank you.